Good morning, everyone. I think we should start our grand rounds. My name is Sanjay Asthana. I'm Associate Dean for Gerontology and Head of the Division of Geriatrics and Gerontology. Dr. Rick Page is out of town and he sends his regrets. It truly is a pleasure and an honor to introduce our speaker for today, Dr. Shari Ling. Dr. Ling is the Deputy Chief Medical Officer of CMS, the Centers for Medicare and Medicaid Services. She also has academic appointments at the Johns Hopkins University School of Medicine in the divisions of rheumatology and geriatric medicine. Dr. Ling received her MD from Georgetown University. She then stayed there and joined the internal medicine residency program, completed the internship residency, became the chief resident, and then joined the fellowship program in rheumatology at Georgetown. From there, she decided to become a geriatrician and went to Johns Hopkins University Geriatric Fellowship training. So she received 2 dual fellowship training in rheumatology and geriatric medicine. Following completion of her geriatric fellowship, she decided to stay back at Hopkins as a faculty and really directed a number of their very well-known clinical services within Geriatric Center at Johns Hopkins. Following that faculty appointment, she then decided to move to NIH. She moved to NIH in Bethesda and worked at NIA, the National Institute on Aging, for over 9 years as a clinical scientist in the intramural program. And in 2000, she moved to 2009, she moved to CMS. Initially as the medical officer, and then recently she became the deputy CMO of CMS. You'll hear some amazing things that Dr. Ling has done since her leadership role at CMS, and especially as it relates to care of older population. Dr. Ling has received a number of awards, including the Davis Scholar Award from University of Southern California, where actually she did a master's as well. And then she also received a Georgetown Outstanding Achievement in Ambulatory Care for her contributions in that area. Dr. Ling has published over 75 papers and book chapters, and many of them relate to issues in caring older adults with multiple comorbidities and so on and so forth. So it truly is a pleasure to invite her to make a presentation entitled Meeting the Healthcare Needs of an Aging Population. Dr. Ling.
Thank you. Well, good morning, all. It's certainly an honor for me to be with you all today. And thank you so much for the kind introduction and the warm welcomes. Really appreciate it. I chose this title because, in a way, the title is reflective of my path of career development, in that I actually started out as a gerontologist, a clinician in gerontology, providing direct care to patients and families with dementia, counseling older adults, and then went to medical school to complete the package, because I did not understand what the medications that people were coming in and out of the clinics were intended to achieve. That same question actually runs through our thinking and emphasizing the importance, really, of evidence-based policy. And so many of you who are in clinical science, in basic science, translational science, I thank you for your work. The charge is really quite monumental, and we rely on you to provide the evidence that we then can translate into evidence-grounded policy. So I will mention a disclaimer. Please don't read all of the fine print, but just suffice it to say that the policies that I will be speaking of today, things change extremely fast in the world of policy. We go through rulemaking. The rules originally as proposed are modified and evolved in reaction to and in response to public comment. And so there will be new developments in policy, refinements of policy, and so it's always worth checking to make sure that what I have said remains current, particularly since I know this event is being taped. So those of you who are going to listen to this in 6 months, please check the website. So the learning objectives today are really to provide you with a high-level overview of some of the key program and policy levers that are in place and will be utilized to achieve high-value care. And highlight a few demonstration and innovation center programs that are evolving. And finally, summarize the system learning opportunities and challenges that we are in the midst of. So as a reminder of scope, CMS is considered a payer, but also involved in some way touching upon the lives of 1 in every 3 Americans. And it becomes enormously challenging as we think about the aging population, in that the population of beneficiaries that we have, remember that it's not just an age-defined benefit, but it's also a benefit based on meeting disability criteria. And so it's a heterogeneous population. And the population is becoming increasingly heterogeneous over time, and in fact really enriched with older adult patients that you are caring for and that you are figuring out how to care for amidst multiple chronic conditions. And this actually has gained recognition at CMS, and that this is an important challenge in that the complexity grows not just from the clinical perspective and what you need, how you manage these people who have multiple competing needs and medications, but it's also enormously costly, where the outcomes that are driven to by individual diseases may compete and then ultimately result in deleterious outcomes such as unnecessary or avoidable hospital admissions, emergency department visits, and 30-day readmissions. So, we are amidst delivery system reform. It is an exciting time to be in the practice of medicine. I still see patients at the VA as a dementia care provider in a consultative role, and also in the rheumatology clinic in a consultative role. So what I see evolving over time is a move from individual, isolated, provider-centered instances of care to a systemness. That is care that is better coordinated, and this is something that you all here in this audience have been at the forefront for quite a while. It's now we are operationalizing this to make it to build the capabilities to enable exactly that. Well-synthesized, coordinated continuity of care for the beneficiaries that we serve. Part of this system redesign is that the reason for it is that we've come to recognize that this fee-for-service system is really not sustainable, nor actually is it in the best interest of the patients that we serve, in that, do we really need to, again, send that list of medications hither and yon and in hopes that someone will actually receive the right list because the patient is depending on it, right? So fee-for-service provides payment, but it's a payment based on volume. It's not a payment based on value. So we're fast moving in the direction of value-driven care, and care that is well coordinated. And it really serves to drive towards 3 goals, and this is, this was initially introduced by Dr. Berwick as the triple aim, then the 3-part aim, but it really is now, the here and now is to achieve better care, smarter spending, and healthier people. And if you think about each of these individually, you realize that each is driven by each one of us, right? Whether we're geriatricians, internists, cardiologists, orthopedic surgeons, we each own a part of attaining these goals. And the system redesign is there to build recognition, insight, and also provide incentives to achieve all these three aims. We also know, though, that transformation of healthcare at the point of care, at the front line, requires evidence, that is comparative effectiveness evidence, that the right evidence be available, that we focus on delivery of high quality care, that is, be able to measure quality measures and use the measures that matter, that drive towards improved outcomes, that we have capable technologies and infrastructures, health information technology, that we align payment incentives so that we are all rowing in the right direction. And my kids would say it's a push me, pull you. It's like, yes, exactly, that's where we were. We are actually now reversing, so we're driving in the same direction. And I'm really delighted that we have residents, house staff, and very long-lived residency director present here today, because this last bullet is about training of clinicians and multidisciplinary teams. And if we cannot achieve that, all that we put in place is not sustainable. So, to the first objective. So I will just cover for you at a high level some of the different programs and levers. These slides will be made available to you that CMS has authority to implement. And I'm going to first start with coverage. And coverage for the reason that that is probably the closest that the policy comes to the evidence. In fact, there are pathways to coverage in previous, or this still is the case in the current state, and we're moving away from it, whereby services are covered because they're requested. Now, the preferred road to coverage is that a given therapeutic treatment or service, that there is evidence to suggest that that treatment or service actually results in better outcomes and meaningful health outcomes, right? And if you think about a single prescription that you write or a therapeutic intervention that you make, ask yourselves, does it translate into improved outcomes? Now, how about diagnostic tests? I in clinic order a number of diagnostic tests. The onus is on me to ask myself, how will I use this information? And this information that is yielded from any diagnostic test should be meaningfully used in the care and management of the patients. It is hard to operationalize what that looks like and to be able to measure that. But it should translate into improved outcomes. Now, on the bottom of the slide here, in Medicare beneficiaries. So when we talk about these coverage policies in the context of Medicare, the evidence has to be sufficient to demonstrate that a given treatment or service results in meaningful improvement of outcomes in the Medicare beneficiary population. So, I will say that one of the most common reasons a treatment or service that comes into Medicare with a request for national coverage is not covered is because there is not sufficient evidence that's applicable to the Medicare population. And those of you who are clinical scientists recognize that this is really challenging because this is about recruitment and retention of older adults in your study populations. It is often asked, then why is it sufficient? This is an FDA-approved device or service. Why is that not sufficient for purposes of coverage? It is because Medicare, CMS, and FDA have different authorities. FDA's authority is about efficacy and safety. CMS and Medicare is about applying that to the Medicare beneficiary population for clinical utility. So, when you think about designing your studies, keep that in mind. Now, I mentioned the aging population and what this looks like. So, this is just a figure to depict the population of fee-for-service beneficiaries in 2012. And what we have here in blue on your left is that only one condition in that population, in all of Medicare. So, as you can see, autism, Medicare beneficiary population, fairly high prevalence of just having that one condition, about 30%. But look at heart failure, stroke, chronic kidney disease. Less than 3% of the population has just that. So if you think about driving to meaningful outcomes in this beneficiary population and you're focused on an individual condition, you can see how this could go very badly, very quickly. So, and just to highlight, if you have, if the condition of heart failure is present, chances are you actually also have diabetes, hypertension, prior stroke, hyperlipidemia, arthritis, and all of the above. So what is in purple is the population that has 5 or more conditions. That's on that side of the map. So you can see that the population, and this is in 2012, is becoming increasingly complex, critical to focus on outcomes that are meaningful for this population. So we have to face our ongoing dilemma: is the evidence sufficient? How do we get the evidence to be sufficient? How do we recruit and retain a population of subjects that then would be applicable to the Medicare population if you are interested in having that treatment of service covered by Medicare? So, and when we consider evidence, and this is our process of evidentiary consideration and review, first of all, it starts with, does that service fit into a benefit category? That's really important, because if it does not, even as noble and as appealing as a treatment or service might seem, it's a non-starter for Medicare coverage. And then the question becomes, is there sufficient evidence for improving outcomes, or that service is, diagnostic test is meaningfully used in the care and keeping of patients? So enter in the Affordable Care Act, enter in the Secretary's charge of setting value-based payment goals and redesigning the health system to achieve better care, better health, and smarter spending. The Secretary, in her New England Journal perspective piece, called out 3 vehicles to achieve this. That is, paying providers differently, so that is paying for value, not volume, delivering care differently, and this is something that you already do here in your health system, which is not isolated events of care, but synthesized, well-synthesized care, primary care redesign, how we care for patients differently, and how we distribute information. So that distribution of information means data. It means quality data, it means resource use data, data that can be used for public reporting purposes, for scientific inquiry, for messaging, and for a status check on where are we in our progress towards a healthier population. So we have had long-standing quality reporting programs that all are now aligned to the 6 national quality strategy goals, which include making care safer by reducing harm caused through the delivery of care, strengthening person and family engagement as partners in their care, effective communication and coordination of care, promoting effective prevention and treatment of chronic diseases, working with communities to promote healthy living and making care affordable. Now, the message for person and family engagement as partners in their care, this is something that we in primary care, in geriatrics, it just is something that we have always done. What matters to you? What do you want to get out of this visit today? What do you want to get out of your treatment plan? And let's drive there together, right, with a risk-benefit assessment. It is difficult as an operational agency driving national policy to know what that actually, how to drive to that. So what we have done at CMS is we have inserted in every of our Center for Clinical Standards and Quality contracts language that requires quality improvement organizations, improvement networks that are evolving out there, that there must be some element of how do we address and bring people in to be partners in their own care. So I mentioned quality. Now this is the landscape of quality reporting programs that go anywhere from physician quality reporting system in the clinical outpatient space to inpatient hospitals to post-acute care, which is a new group of quality reporting facilities for us, to nursing homes, long stay, short stay nursing homes, and also end-stage renal disease facilities. Now enter in the Impact Act of 2014, Improving Medicare Post-Acute Care Transformation, Impact Act. Now what this act permits us to do is for the first time standardized data elements across post-acute care settings, including, so that's home health, inpatient rehab facilities, long-term care acute facilities, skilled nursing facilities, in important areas that require that standardization that will permit us to know if our patients, our people who we are caring for, are getting better or worse as they transfer from one care setting to another. Important concepts like mobility function. Can a patient walk? How far can they walk? Can they take care of themselves? Right? This is what we need to be free living people out in the community. So same for the patients. So for the first time, the Impact Act permits us and actually creates the expectation to standardize these data elements. And we started working on this in the context of the Post-Acute Care Payment Reform Demonstration Project when I was a medical officer 5 years ago. Slow, hard slog, standardizing what mobility would look like. What should be the required data elements for all care providers across care settings? Unfortunately, the Impact Act actually does not include hospitals, but I think there's opportunity to get there because if we think about discharge planning, how might that look differently? If you as a discharge planning professional know where your patient is when they start their hospital stay, where they end up, and what needs do they have that we should find appropriate referrals to. Should they be in an inpatient rehab facility? Can they do those 3 hours of therapy a day? Or should they be in a skilled nursing facility? We finally are going to have the ability to make comparisons about what kind of care can be provided by those facilities, and that information can be available to patients and planners. So, this act actually requires the data uniformity, as I've previously mentioned, and that standardization that will permit us to know how things are going over transfers for purposes of planning and referral. Now, one area that is very tricky that I would like to call your attention to, because I know many of you are working in the dementia care space. So, how do we assess cognitive function, right? In a way that we know translates into can manage their medications, can manage their living outside of a facility. I will say that the tools that we have had that we rely on and that we have made available, encouraged providers to use in the outpatient setting to detect that there's a cognitive impairment problem in the context of the annual wellness visit likely does not meet the needs of that assessment at points of care transition. So what should we use, right? And remember, it has to be standardized. It has to be applicable across care settings with floor and ceiling effects in play What should we use? What can we focus on? We are also working on resource use, because it is about smarter spending, and that information has to also be publicly available. So you may be aware of this, but we actually CMS releases each year public use data files, including all Part D medications. We release cost data for all healthcare providers who are enrolled in Medicare that you can actually review and know. And also, with the Physician Sunshine Act, we also make available the information on industry sponsors and the amount that that sponsor has given to individual clinicians over time. So CMS is really big on transparency and making that information available. And this is one instance, probably one of the longer-lived compare sites, Hospital Compare. And I will also mention to you the reason to call to attention Hospital Compare is quality measures have to, by statute, be posted on Hospital Compare for a full year before they can be considered for hospital value-based purchasing. So by looking at Hospital Compare, you can know, likely, based on the performance, what will be proposed in future years for rulemaking for hospital value-based purchasing. And so we are actually transitioning to a point of value-based purchasing, and Hospital VBP is one of two programs that were first out of the gate. And Hospital VBP has evolved over time, initially focusing on process measures because the statute required we include measures, quality measures, and because those process measures were what were available, tested, and demonstrated with acceptable test characteristics and endorsed by the National Quality Forum. So as you can see, that has evolved over time, and what's depicted in the pie chart are the weightings. So importantly, we have patient safety, which is an ever-present factor and domain in value-based purchasing. We also have efficiency and cost reduction, that is looking at overuse, measures of overuse, inappropriate use, and it is balanced with outcome measures, which is 25%, but equally balanced by patient experience of care. So that is an important message to hospitals and also to health systems that patient experience of care matters. Now, the secretaries also set some very bold goals in early of 2015, which was just last year, the first goal of which that Medicare payments are tied to quality or value through alternative payment models and specifying categories 3 or 4, APMs and population-based payments of 30% by the end of 2016. We actually met that goal, giving you an idea of the pace of the evolution of delivery system reform and the movement to alternative payment models. Now, the second so the second goal is that at the end of 2018, that 50% of payments will be through alternative payment models. So they're high bars, but we believe we can make it because we are ahead of schedule in attaining these goals. Goal 2 is that of Medicare fee-for-service payments are tied to quality or value, so that would be categories 2 and 4, 85% by the end of 2016 and 90% by the end of 2018. And these are the categories that I mentioned. So on the top row is the description, and the bottom provides examples. In brief, category 1 is fee-for-service. Category 2 is fee-for-service with some link to quality. Category 3 is alternative payment models, including, as an example, some ACOs, some medical homes, some of the bundle payment programs, but that are built on fee-for-service architecture. And category 4, which is population-based payments. And this actually provides a landscape of the trajectories over time for each of these categories. Now, many of you have heard about the Medicare Access and CHIP Reauthorization Act of 2015, which is MACRA. And this is about moving to alternative payment models. Now, this act repeals the sustainable growth rate of formula and changes how Medicare rewards clinicians for value over time. It also created the Merit-Based Incentive Program, or MIPS, that streamlines the 3 previously implemented programs of physician quality reporting, PQRS, value-based modifier, and the EHR incentive program for clinicians. So that is all now going to be consolidated into a single program. And it also importantly provides bonus payments for participation in eligible alternative payment models. So emphasis is on eligible because not all payment models, actually alternative payment models, meet criteria for advanced alternative payment models. So these programs are being streamlined into one. And as clinicians, you may be asking yourself, am I subject to MACRA and MIPS? If you are an eligible professional that provides fee-for-service for Type B services, then you may. And eligible professionals here is defined as physicians, physician assistants, nurse practitioners, clinical nurse specialists, nurse anesthetists, and have participated in Medicare for more than 3 years. Now, which of the alternative payment models actually count as advanced alternative payment models? There's a distinction. So alternative payment models in general include the CMMI demonstration models, Medicare shared savings, and other demonstration projects. But APMs that are eligible for consideration as part of MACRA, whereby clinicians can earn a bonus of 5%, must meet specific criteria. So they must include quality measures such as those used in the PQRS and comparable to the Merit-Based Incentive Program. It must require the use of certified electronic health record technology and also bear more than nominal risk or monetary losses or be a medical home model. So this just gives you the landscape of the timing of the transition from fee-for-service from the perspective of updates each year. So the physician fee schedule applies a update each year. That will continue through 2019 at 0.5% and continue over time thereafter. But with MIPS, that comes into play a bit later, so 2019, and also the alternative payment models in 2019, but using 2017 as the performance year. So as you can see, the 5% bonus is really applied to alternative payment models, so they're advanced alternative payment models. So it's worth focusing on how we as a system and how we as clinicians contribute and get there. So I will spend just a little time talking about some of the demonstration and innovation center programs. And those of you who are working on the Healthcare Innovations Awards and the Medicare and Medicaid demonstration projects here in this auditorium, thank you for your work. It is a learning process. We are learning from all that you do, and we are learning quickly. So as you know, the CMMI actually has a unique authority set through Section 3021 of the Affordable Care Act, and that is to test payment and care models. And payment and care models, how these models will be used to demonstrate scalability, that authority and determination rests with the actuary, the Office of the Actuary, requires that those models demonstrate higher quality, lower cost, preferably both, or at least stable quality with lower cost, or stable cost with higher quality. So those are the criteria for scaling and spreading. And this is the profile or of the portfolio of the CMMI work, and it includes how we pay providers differently, including primary care transformation, many of you who are already involved in this, and accountable care organizations, so paying providers differently, delivering care differently, including the work for our HACQR awards, and also distributing information differently, which includes shared decision-making that's required in many of the care models that are mentioned above. Now, ACOs are flourishing, and as you can see, the darker distribution on this heat map, the more numbers of ACOs, and these were established by way of the Medicare Shared Savings programs. This also includes the Pioneer ACOs and the Next-Gen ACOs, as well as comprehensive ESRD care model programs. And the Next-Gen ACO actually builds upon what we have learned and are learning through our ACO program. And what this model actually brings to bear is higher levels of financial risks and rewards than what was put forward in either the Pioneer ACOs or Medicare Shared Savings. And this will test how strong financial incentives for ACOs can actually improve health outcomes, with highlights for greater coordinated care as vehicles. So this information and all of the information about ACOs and all the CMMI programs are available on the web. And I will say it is probably, for CMS websites, it is the best up-to-date information that provides milestones, progress, and even reports of, so HACQR awardees, you know that you had to submit your reports for evaluation purposes, but also the first-year reports are available to the public through this website. And so you can actually go in and search where's innovation happening by state, by region, and that's designed so that you can actually find new partners in coming up with new solutions that you may not have thought of, and to learn from each other. So the comprehensive primary care model is also showing some positive results. This is convening Medicaid and commercial payers together to support primary care transformation, which is something that you have already done, but about 2% reduction in Part A and B expenditures observed in year one among 7 of the CPC regions, which is actually really encouraging. And some of those lessons learned, including how they have driven towards reduced hospitalizations, ED visits, and unplanned 30-day readmissions. Really, those are process improvements that can be shared and built upon. So the CPC Plus model was just announced in late April, which is a 5-year multi-payer model beginning in 2017 of January, and again provides 2 tracks of participation, the second track of which actually targets and highlights vulnerable and complex populations that require extra attention. And part of that also includes then higher payments for providers who deliver those services, and to the level of some of the care that's provided by hospital care providers. Just acknowledging the importance of you, the clinician, in delivering care to complex populations. Now, bundled payments, those programs are also really growing rapidly, and there are 4 models. Models 2, 3, and 4, which is, tying together acute and post-acute care in various ways, prospectively, but also retrospectively, and really synthesizing and removing that barrier that we see at those care points of transition by paying for the entire episode. These 3 types of models, 2, 3, and 4, actually do count as advanced payment models for purposes of how we have proposed it for MACRA. So one example is the comprehensive care for joint replacement. It's a test of payment across a broad section of hospitals. Again, thinking about the start of the episode is when someone comes in for a surgical procedure, but all that happens afterwards. All that is bundled together. The hypothesis there is paying for that episode actually will provide incentives to coordinate care better so that there is less risk of unnecessary admissions to the hospital, greater follow-up, better coordination on matters that may be beyond the context of what a typical surgical episode would look like. That's also important. Now, I will end with some of the system learning opportunities and challenges. So, how many of you have worked with quality improvement organizations over time? Yay, that's good. So, QIOs, the quality improvement networks, there's actually been a redesign of the QIOs into a beneficiary protection QIO domain, and those that focus on improving quality to separate review from improvement. And so we are continuing work, including through special innovation projects. I know Amy is actually involved in one, that focus on improving health, providing better quality, and smarter spending through rapid cycle small tests of change, but also a model test of helping practices transform to meet the needs of the population at hand in a way that then achieves the 3 goals. And so it's providing support to clinicians and their practices. And this support is by way of collaborative peer-based learning, joining a learning community, developing partnerships that I alluded to, and an opportunity of bidirectional sharing of information and spreading of best practices and sustaining those practices for clinicians, patients, and families. And how CMS did this. How many of you have heard of Transforming Clinical Practice Initiative, TCPI? Okay, a few of you. So this also has, if you Google search Transforming Clinical Practice Initiative, this is critically important because this is a large-scale investment by CMS to practice redesign and practice improvement. This will support over 140,000 clinician practices over the next few years to improve quality and to enter into alternative payment models. And the 2 network systems that have been created are the Practice Transformation Networks. That's 29 PTNs were awarded contracts, and to develop and support peer-based learning networks designed to coach and mentor and assist. And there's also 10 support and alignment networks provides the system of workforce development utilizing professional associations and public-private partnerships to share materials, best practices, improvement tools. And so we project that this will evolve over time. That is the application of this technical assistance and also this model test where we have already set aims, we begin to recruit practices, and we're on target by and large into TCPI, teach these practices, provide them with the tools to use their data, to collect their data, use their data to improve, and then achieve aims, set goals, achieve aims, and improve through small tests of change over time. So the key benefits to participating is that this will help clinicians optimize those health outcomes for their patients. It promotes connectiveness and coordination with your patients, but on behalf of your patients as well, and where you can actually learn from high performers. Anticipate there will be a release of a Medscape, they call it a expert opinion poll or expert opinion piece on transforming clinical practice. So it will provide you with all of the resources and links that are necessary to get information and how to get involved here. What this will permit you to do is spend more time with your patients doing what it is that you always thought that you would be doing, right? Helping them achieve their goals of care, providing the caring that's required in the clinical setting. But it also will align and prepare us as a nation towards alternative payment model participation. So in a parallel universe, so there's the how practices will transform. There's also payment, and how will payment transform? We have to go from fee-for-service through fee-for-service architecture to these alternative payment models. And by the way, you know, the intent is to get more people into these alternative payment models. There is the Healthcare Payment and Learning Action Network that has recently been designed. Not sure if any of you participated in this, but there was a 2-day summit where all that major health systems actually came together with the Quinn QIOs and the hospital engagement network representatives to talk about how we actually do this. Right? It is about learning what are the pain points in primary care, as an example, that would keep you from getting to focus on higher value care, delivering higher value care. There was discussion about how do we construct a learning and action network? What would be the criteria to lead such an entity? And also, how do we share best practices for getting people into alternative payment models? So this is about getting into APMs and sustaining that effort and what the best strategies are. And all that information, including any materials that are available on the healthcare that were made available through the Healthcare Payment and Learning and Action Network, can be accessed here. And I mentioned earlier about the model summary and the time points and milestones. All that is available on the convention is on the right side of each of the web pages for CMMI. So it's readily available information. Now, coming full circle to transformation of healthcare at the front lines, we talked about all these different elements, what's required for transformation. And we know we can improve. This is an example of that success. So this is the Medicare all-cause 30-day readmission rate that is depicted and shows demonstrable improvement over time. And this is the Medicare population at large. 565,000 readmissions avoided to date. We also have been able to reduce hospital-acquired conditions by 17% over 3 years. So those HACS from 4+ million to 3+ million, significant improvement. We've also been able to save $12 billion of cost savings over that 3-year period of time. And we actually calculated our colleagues at the Agency for Healthcare Research did these computations on our behalf. Some 50,000 lives saved in that 3-year period of time. So how did we do this? This is evidence of all of this. We put in place quality measures. We align payment incentives. We provided disincentives for readmissions that are not necessary for hospital-acquired conditions. We also built on the existing evidence of effectiveness for how to achieve that, and we utilized information technology and applied technical assistance. And I will say technical assistance is not just about distributing tools. It is also about the culture of improvement that I know you have adopted here. And where this comes into play, we have learned it, and in our examination of the data and where are the points that hospital readmissions are still high, catheter-associated urinary tract infections are still high, we actually know where those points are. And when we look at why those points are high, it's because there either hasn't been adequate leadership buy-in to the culture of safety or improvement, or the adoption of known best practices, or the ability of practice as a team. So catheter is in, for 2 days. Please have your nursing colleagues ask, doctor, is this catheter still necessary? It is all about how we practice differently as a team. And our training of clinicians will help us sustain this. So it's back to the distribution of information. So this is a screenshot from the CMS dashboard. I alluded to this in an earlier slide illustrating the complexity of the Medicare population. This is a demonstration of individual chronic conditions at a national level. Each condition can be clicked upon, and you can actually see, this is an example, Alzheimer's disease, that on the right side of the screen, the percentage in the nation, or for your state, or for your county, what percentage has what number of other conditions. So this actually helps with planning purposes. It can help for research purposes. And finally, this one is for Dr. Amy Kind. This is the Disparities mapping tool that we recently introduced to public view. This began in 2012. You can look at 2013 and 2014. It's a heat map built on Medicare claims data, but you can look geographically for the prevalence of individual conditions, but also not just prevalence, but for certain conditions, you can actually look at readmission rates, emergency department visits, and you can actually dive down and look for those hot spots. And we ask ourselves then, how do we help these communities to improve? I will also say that, this is Medicare claims data. These are claims administrative data. But they're a reflection of something much bigger, much deeper, that we as CMS cannot access, right? It's about that filter of context, of culture. It's about all that these little dots represent that we cannot really get at. But what we can do is point the way. So I will close with the following question for us all. So what can we do as individuals, as a group, to help our system achieve the goals of better care, smarter spending, and healthier people? How do we eliminate patient harm, focus on these goals, engage in accountable care that delivers higher value to our patients and families? What do we need to do to invest in the appropriate infrastructure that permits the flexibility to achieve all that we need to do in meeting the needs of a very complex population as a system? And how do we really embrace the notion of setting goals, enacting small tests of change, learning from that change, and improving in relentless pursuit of improved health outcomes? So with that, I have actually added a variety of slides for in the appendix that go into much greater detail on a variety of the CMS programs. But I thank you for your attention. Again, thank you for the warm welcome, and I really am honored to be here. I'll invite questions. Thank you. I'm going to read, I've written down your questions and I'm going to repeat them per Clint's request back there. So question one is saving dollars and Medicare's ability to negotiate for better pricing with pharmaceuticals. As you know, the ASP, average sales price plus 6%, has been in statute. And so CMS has not had the opportunity to negotiate prices. Now, having said that, we recently announced the Part B medication, the Part B drug demonstration project. It is open for public comment. It actually, there is a couple of paths or a couple of phases of this, and I really don't know the details, but suffice it to say, part of it is testing the hypothesis that if you actually reset that ASP plus 6, so if you decrease the ASP, right, the average sales price of what Medicare will pay for, and give a flat fee associated for payment of a given drug. The hypothesis there is that there will be less temptation to choose the higher cost drug, the more costly drug, when there may be other equally effective medications available. That is something that is in focus. We're very mindful of the high cost of medications. CMS recently also released a watch list of medications, and it includes the high costers are antiviral agents, some of the biologics, some of the chemotherapeutic agents. The chemo agents, I think, were left off of the watch list, but are part of the Part B demonstration project. That is something that is definitely on CMS's radar as a problem, high cost, creating issues of access, right? But we have to demonstrate that we can do this differently through the Innovation Center Authority. So that demo is actually, there's a public comment period that you can provide comments. That's a good idea. I will tell you, not everybody loves it, but I think is the right direction. Again, thinking about the incentives, aligning incentives. To the point of, and your second question was quality for care and the enormous pressures to see more patients. I think we're very clear in setting out our metrics, our performance metrics now, in our paying for higher value care as opposed to volume care. So I think I would anticipate that there will be a shared movement towards delivering higher value care. And that's certainly of what I heard at the Healthcare Payment Learning and Action Network, where there were plan representatives and other entities beyond Medicare. So again, it gets back down to what are the outcomes that are most meaningful for patients and families, and how do we drive towards them? And I think we have the perfect opportunity now through our demonstration projects, through the advanced alternative payment models, to accomplish exactly that. That is the construct. It is not based on fee-for-service. It is paying for value. So that's really exciting, and there are incentives to drive in that direction. So thank you for your question. Other questions? Please.
Philosophically, can you speak to kind of striking the right balance between outcome metrics and process metrics? Obviously, when you kind of talk about improving quality of care in the context of a visit, one of the complaints that providers often have is that I don't have time to get to the important stuff because I have to do smoking cessation, all this stuff.
Right. Sure. So the question is, could I speak to finding the right balance between outcome and process metrics? There has been tremendous focus on outcomes that we can tie to payment, right, to achieve value. And there's also been an emphasis and an evolution of the quality measures that actually now focus more and more on outcomes rather than process. There is a graduation, if you will, of the quality measures that are used in programs when alternative and better measures become available. And many of those would fit in the process category, right? But process measures or any measures, especially in the initial stages of a program, were implemented because those were what were available. So if there are newer, better measures, even on a population level, those, and if your practice is designed to support population-based payment, then certainly those type of measures could be implemented in the programs. And as you know, so the proposed rule is posted for MACRA, and part of MACRA includes quality measure development that would support alternative payment models. So, there's definitely opportunity, there's interest in that. I will also say, though, to your point of specifically smoking cessation is a department priority. And yet, we're not able to measure those quality measures that are tested and proven in the outpatient setting in a hospital. It may not be appropriate. We don't even know it's valid, so we don't. But we do measure it in the outpatient setting. Having said that, the practice redesign creates opportunities. Not everything has to be done by one individual, right? Geriatric assessment, as an example. I mean, we had our nurses' aides who check blood pressure, record the walking speed. As people were, we just put the marks on the floor. I mean, so that was information that we could use. We had a nurse actually doing the medication reconciliation on one day in one clinic, and a pharmacist on another. In another care setting. So VA, we are delighted to have our geriatric pharmacist. I don't know how I could actually survive without her. So I think, it causes us to think about how we practice differently and practice more as a team. So I think that opportunity is here, and it is now. And thank you for your question.